This patient was referred to me for consultation and endodontic retreatment of tooth number 31. Porcelain crown, build up, previous root canal, and you can see there's a large periapical relucency associated with the tooth. Short fills. Again, short fills don't matter as long as there is no lucency here. There's no infection. This root canal was done by a local endodontist. I know the endodontist. Was done by him, and 8 years ago. Root canal was done by him 8 years ago, and he's retired since. So patient had gone and seen her new dentist, and this periapical relucency was found during a routine examination and x-ray. Patient said she had no symptoms. And you guys know by now, in situations like that, when patient has no symptoms, tooth responded within normal limits to percussion palpation, probings were 2 to 3 millimeters. I always ask for an x-ray from a year ago, 2 years ago, 5 years ago, before the root canal, ideally, to see if the dark shadow was there. If the dark shadow was there, has it gotten smaller? Has it stayed the same size? Was the periapical relucency was even there before the root canal? Before I tell the patient, hey, we need to redo this root canal. I need some more evidence. Again, if patient has no symptoms and everything checks out okay, no pain, patient doesn't complain to any pain ever after the root canal, patient doesn't have a sinus tract or swelling, patient tooth response within normal limits to percussion, palpation, biting, and all that stuff, then I request an x-ray, ideally, as I said, as far back as possible, of the tooth to see if this periapical relucency was there or not. Or perhaps if it was there, has it gotten smaller in size, or has it gotten bigger, stayed the same size, and what have you. So we were able to get an x-ray from of this tooth from before the root canal was done. So let me show you that x-ray. And that's the x-ray. Before the root canal was done, tooth number 31, root canal and crown. And you can see there was no periapical relucency before the root canal. And of course now there is one. So this is considered an active infection because the periapical relucency was not there before the root canal and occurred after the root canal was done, as you can see right here. So this is an active infection, and that's when we recommend endodontic retreatment. So I presented the case to the patient, and this patient actually used to be a dental assistant herself for over 20 years. So as soon as I showed her the x-rays before the root canal was done, the fact that there was no periapical relucency before the root canal and now there is one and all that stuff, she completely understood. Of course, even if she wasn't a dental assistant, I always make sure that I spend time with the patient and I educate my patient. So we can go over options with the patient, and the patient has all the information that he or she needs to make the decision, which decision is best for them. So I went over options with the patient. We can redo the root canal and prognosis, guarded. I can't guarantee anything, no promise or guarantees. We do our best. Time will tell. Within a few months after we've redone the root canal, the periapical relucency should shrink in size or go away completely, but I can't guarantee it. The other option would be to extract the tooth. That's the alternative to redoing the root canal. Because there is no let's leave it alone. Leaving this alone will only cause more bone to get eaten away and destroyed by the infection. So you don't say just no treatment. No treatment is not an option. So either we redo the root canal, no promise or guarantees, only time will tell, or extraction. Patient said she wanted to try to save the tooth, so she chose endodontic retreatment, non-surgical endodontic retreatment. Again, you can see that the endodontist didn't go all the way to the end. And again, it did filling short. There's nothing wrong with that. Problem is, if you fill short, you didn't instrument all the way to your desired working length. left necrotic tissue and bacteria behind, and then filled short. Of course, that's a problem, and this is the problem here. So I went through the porcelain crown today, removed the buildup, and lo and behold, there was leftover cavit and a cotton pellet. So this dentist had left cavit and cotton pellet under their permanent buildup and crown when they did the root canal. When they did the crown, I'm sorry. Anyway, so remove all of that, remove the gutta percha. I used chloroform and stainless steel K-files. And it took me a while to regain patency. There was ledging and blockage here and here. But take a look at the post-op now. And here's the post-op. As you can see, everything went beautifully. I went through a few packs of 08, 10, 15, all C files to be able to regain patency in these three canals. You can see patent here, and use 6% sodium hypochlorite copiously, and sonically and ultrasonically activated the 6% sodium hypochlorite, and refilled, reobturated the canals three-dimensionally. And again, as you can see, everything went beautifully. Went ahead and temporized the tooth and referred the patient back to her dentist for the permanent restoration. And this is another angulation. And you can see all the anastomosis between the mesial canals here. And distal canal had a ribbon-shaped anatomy, and you can see that there.